Today we are going to talk about this particular patient which is presenting with a swelling left limb and which is absolutely painful, and there is absolute tenderness in this particular limb, and there is erythematous changes in the skin with slight bully present here and there, and patient is having a fever, and on pressing by thumb there is a formation of pitting edema. So we have to diagnose the condition, and this particular condition is absolutely enormously important for final MBBS students and also for the PG medical entrance examination, and also for overseas licensing examination, because this particular condition are generally presented with a clinical scenario in MRCP and USMLE both. So practically this condition is telling the thing there is a swelling of the lower limb, and this is unilateral condition, and there is extremely painful condition, and there will be tenderness and there is a fever, and this sort of condition, this is actually a case of DVT, deep vein thrombosis. Why this condition? We are going to talk about the pathology, pathogenesis. We are going to talk about certain clinical signs in the both acute and chronic cases, and also we are going to talk about the treatment aspect. And there are certain criteria which are associated with it, and certain radiological finding. This is absolutely, as I've stated, this is absolutely one of the most important topic, and I'm expecting quite a few questions from this particular presentation, particular class presentation in forthcoming summer season examination in both PG entrance and step-up examinations. So let's go for the pathogenesis. This is a case of DVT, deep vein thrombosis, and why it is so very important, because this is a unilateral condition out here, this particular patient, but this is bilateral in 30% of the patient. And why it is most worrisome, because this particular condition can present as a pulmonary embolism without having any sign of deep vein thrombosis. So the patient can have pulmonary embolism, which will lead to right ventricular failure and death. So this is quite a fatal condition too. So let's go about the pathogenesis of this particular condition. So remember this triangle. This is a this is a VirchowTriad, and mnemonics is she, and this is stasis. There will be endothelial injury and also hypercoagulability. So all these three things leads to clot formation. Exactly what is happening? There is increased clot formation due to inhibition of coagulation factors. So there will be protein C and S deficiency. There will be antithrombin 3 deficiencies too, and there will be mutation in prothrombin gene. And what happens, that increase in factor 5 leading. Just remember, this is the most important factor for this deep vein thrombosis and also thrombophilia, and this can be a future question. And factor 5 Leiden is resistant to inhibition by activated protein C. So this 5 point actually promoting the formation of a clot. So even if the clot forms, but what happens is the clot can be lysed. But in this deep vein thrombosis, the pathogenesis, another aspect of the pathogenesis, there will be impaired clot lysis. Because of the dysfibrinogenemia, there will be plasminogen deficiency, there will be tissue plasminogen activated deficiency, plasminogen activated inhibitor 1 excess. So all these 4 points leads to impaired clot lysis. And there are a few conditions like pregnancy, obesity, diabetes post-op state, malignancy, nephrotic syndrome, myeloproliferative disorder, acute myocardial infarction, diabetes mellitus, hyperlipidemia, hyperviscosity, polycythemia, paroxysmal nocturnal hemoglobinuria, BSET, and TGP and estrogen treatment, all leads to formation of deep vein thrombosis by increasing the factor which is forming the clot, and by impairing the factors which is impairing the clot lysis. this is few clinical signs which are very much important, not for the only PGME or MCQ entrance examination purpose, but also for the people who are going to give the basis examination of MRCP and also for the final ME examination, giving final ME examination. This is Homan sign. What is important to remember, here there is no relation with the pain. And here this is very important thing, that there can be two options that coming up: pain while dorsiflexing the feet, and or there is a resistance in the dorsiflexion. So the answer will be resistance in dorsiflexion, not the pain. So in Homan sign there is no pain associated, but this particular sign is known as Pratt sign, where you can squeeze from the sides, two sides you can squeeze. So this is the area where soleal veins are located, and which is the connection between posterior tibial vein and peroneal vein. And this is the most common area for deep vein thrombosis. We are going to show the picture also later. And here the patient will have tremendous tenderness. The condition is absolutely painful. Our patient will feel the tenderness also. This is Pratt sign. The next important sign is Moses sign. Here, unlike the Pratt sign, we are not pressing it from the side; we are pressing it from the on the cuff itself, and this is called Moses sign. This is another clinical sign. And two important clinical dermatological findings. You can say dermatological finding because it's also involving the epidermis. One is phlegmatia alba dolens. One is phlegmatia caeruleus dolens. Here there will be cyanosis, so it will be bluish discoloration, and alba dolens there will be whitish discoloration. There will be whitening of the skin. And what exactly happening here? Deep venous channels are only involved, and here deep venous channels and collateral both are involved, and it is a pretty serious condition. And here we have to most of the time we have to go for the embolectomy also. So as we have stated that we are going to talk about the anatomy aspect, and this is the soleal vein which is connecting between the popliteal vein and posterior tibial vein. This is the area. This is actually cuff, in the leg. This is the cuff, and this is the most common area of deep vein thrombosis. And this is the femoropopliteal junction. This is little proximal, and here when the thrombus forms, this is most commonly forms the pulmonary embolism. And as we are seeing the Doppler USG pictures, we are seeing two conditions. One will be there will be filling defect in the flow, and this is the soleal vein, and this is the posterior tibial vein. There will be filling defect in the flow, and there will be lack of compressibility, that which is leading to the thrombosis. We are seeing two important things. There will be lack of compressibility also, which will lead to the thrombosis. And the patients can be differentiated in three categories by 30-40 rule. Remember 30-40 rule. The surgery, if the surgery is less than 30 minutes, is a good prognostic factor. If the surgery is more than 30 minutes, it's a very bad prognostic factor. Apart from that, the age is, if the age is according to the 30-40 rule, if the age is greater than 40, which is going to be the bad prognostic factor, but if it's less than 40, it is going to be the very good prognostic factor. And one thing we have to remember, certain surgeries like orthopedic surgeries, urological surgery, and extensive pelvic surgeries are very, very serious condition which leads to formation of deep vein thrombosis and also pulmonary embolism. So we have to think about the treatment aspect also. In the treatment aspect, number two things we have to do, either heparin or warfarin. And among the heparin, fractionated low molecular weight heparin is preferred than the unfractionated heparin. And the unfractionated heparin is actually determined by the APTT, and it is preferable to preferable to keep it within the 1.5 to 2.5 level range. This is and the warfarin is determined by the PT, prostaglandin time, or INR, which have to be kept within 2 to 3. And there are certain supportive factors like early ambulation, which is triggering the pump mechanism of the veins in the cuff, and also pneumatic compression device. This is the pneumatic compression device, and this is the where the stimuli are coming. The stimuli or triggers are coming, and this is the compression. It is compressing on the from the distal to proximal aspect, this direction, and there are 3 compression, 1, 2, and 3, and this is being given to the patient. And if it is involving iliofemoral vein, like the proximal aspect in the of the swollen leg, then we have to consider for the thrombolysis. This is the in a nutshell is the treatment of DVT. Now the most important risk factor. Now we are switching from the surgery to medicine, and here the most risk factor they are developing. This condition is developing pulmonary embolism, and it is a real risk factor because this emboli that is forming in the large vein goes to directly pulmonary emboli, which is leading to acute cor pulmonary, right ventricular failure, and death. And most common symptom is dyspnea, and most common sign is tachypnea. And there is increased respiratory rate. There will be formation of central cyanosis. There will be subcostal recession also, and in cases of low risk factors, we can go for the anticoagulation, and in cases of high risk cases, we have to go for the embolectomy. And this is the characteristic ECG finding in cases of pulmonary embolism S1Q3T3. What we are seeing, there is a depth of in the lead one, there will be increased depth of S1 SOFs, and also there will be in the lead 3 there will be inversion of T wave, and also there will be increased depth of Q wave. So one important thing is the S1Q3T3 is the most characteristic finding, and most common finding is sinus tachycardia. Apart from, there will be right axis deviation and atrial fibrillation. There are few scores which are very important, and one of them is pulmonary embolism severity index, and 5 factors are very important there. One of them is age greater than 65, their breathing rate greater than 30 per minute, their presence of cancer, chronic cardiopulmonary disease along with, and also the oxygen saturation. If there is a low risk, the whole total score is coming up less than 1. The death is 1 person out of 30 days month span, and also if in cases of high risk, the death percentage is 10% of the patient affected with 30 days in a month span. We have to remember the investigation of choice in cases of pulmonary embolism is CCT, contrast enhanced CT scan, which is predominating over the ventilation perfusion scan. And the ventilation perfusion scan, there is an important criteria, this modified POPET criteria that is being employed, that used to be employed earlier. Right now CCT is predominating over V2 scan. The gold standard is pulmonary angiography, and we also can do another imaging which is also very good in diagnosing the condition. That is CT angiography. And screening test, one thing that is ruling out, that confidently can rule out there is no pulmonary embolism, which is FDA approved also, that is D dimer. Because the D dimer less than 250 microgram per liter, we can rule out pulmonary embolism. But if the D dimer is more than 250 microgram per liter, that can be due to pulmonary embolism or DVT, but can be due to other condition also. We cannot confirmly tell that is pulmonary embolism and or the pulmonary embolism or this DVT condition, but we have to go for the further investigation, like we have to go for the CT scan and or pulmonary angiography or CT angiography. And this is Fogarty catheter. This Fogarty catheter is used for doing the embolectomy. There are certain X-ray sign and CT scan finding which are very characteristic of pulmonary embolism. One of them is this is Westermarck sign, and that is Palla sign. And this is the pulmonary oligemia. You are seeing pulmonary oligemia out here, and this is the prominence of pulmonary arteries, pulmonary vessels. There is a absolutely prominence of that. This is Westermarck sign, this is Palla sign, and this is Hampton-Hump sign. This is Hampton-Hump sign, and this is this increased density. You can see this is a triangular density is out here. This is Hampton-Hump sign. Another important sign is there. This is melting sign. This is the CT scan finding, and the similar finding can be seen also in the X-ray. That is melting sign. And this is seen also in the it is more prominent in the CT scan. You can see this melting sign is out there, and it is the resolving condition. It is pointing towards the resolving pulmonary embolism. And this is Polo-Mint sign. This Polo-Mint sign. This particular one is on the pulmonary artery, and this Polo-Mint sign is on the saphenous vein. And two more important signs. This is the Fleischner sign. This is in the proximal pulmonary vein, and this is the proximal pulmonary vessels, and this is the distal pulmonary vessel. This is these are the distal pulmonary vessels, and this is called knuckle sign. This is abrupt cessation. You can see abrupt cessation out there. There are two important diseases which are absolutely very important, and this is called May-Thurner disease. This is a pretty new question. This new question can come up from this one. This is May-Thurner's disease, and this is more common in female than male, and it's common in 2nd to 4th decade. Here we have to go for the IV ultrasound, which can confirmably detect this condition, and it is preferred over duplex ultrasound as an investigation of choice. And in this condition, as because these femoropopliteal veins are involved, we have to go for surgical or medical thrombolysis instead of anticoagulant therapy. And after doing that, we have to go for angioplasty and stenting the iliac vein. So it is preferred over anticoagulant therapies. And there is another disease that is known as Paget-Schroeder disease. This is another important condition, and here this time the DVT and pulmonary DVT is happening in the upper limb. You see this upper limb, and this is effect-induced thrombosis. This case is published in one of the foreign journal, and the lady came after some rigorous exercises. She developed this sort of different thrombosis out here, and here is what is happening. There is DVT encompassing axillary and subclavian vein, and this is upper extremity DVT, and it is effort-induced thrombosis. Here we have to do anticoagulation instead of thrombectomy to prevent the pulmonary embolism. And in case the treatment is thrombolysis by catheter directed alteplase. And is there any need of doing surgery out here? Actually, it is related to the certain condition is related to the thoracic outlet syndrome, and there is abnormal lateral insertion of costoclavicular ligament in certain cases of Paget-Schroeder syndrome, and in those cases we have to do the surgeries. Otherwise, we for the it can be controlled easily by anticoagulation therapies. Certain criteria are very important. In the future, the question can be asked. Till now it have not been asked from this particular topic of pulmonary embolism. And one is Wells criteria for DVT, and another is Wells score for pulmonary embolism. Though both are sounding similar, but they are not. And one thing you have to remember, therefore, Wells criteria for DVT, the score spans from -2 to +9. And in cases of Wells score of pulmonary embolism, for pulmonary embolism, it is three grades. One is less than 4 is low pretest probability, 4.5 to 6 is a moderate probability, and greater than 6 is high pretest probability. And these are the important factors which are related with this. And these are two different criteria. This here the score is for DVT is ranging from -2 to 9, and for Wells score it is ranging from this is 4.5 and 3. So this 6 and 10.5, 12.5. So the score is ranging from in these three categories: 4, 4.5 to 6, and greater than 6. So it is dividing it in low, moderate, and high. There is another score that is known as pulmonary embolism rule out criteria. If these criteria are more positive side, we can rule out confidently pulmonary embolism. And these are the points, these are the factors like age and pulse and percentage of oxygen, hemoptysis present or not, exogenous oxygen use, the prior venous thromboembolism present or not, and surgery or trauma requiring hospitalization within past 4 weeks, no unilateral leg swelling. So this is known as PARC criteria. And then there is another score. If the score is more out here in the left hand side, we can rule out the pulmonary embolism. And another score is there, PACE score, pulmonary embolism severity index. Here also, if the score is higher, here you see, this is, if the score is higher, it is pointing to the very high risk. And one thing you have to remember, one important point, most important factor is hospital delay or duration of the hospital stay. It is have directly proportional relationship with the formation of pulmonary embolism. Hope you like this particular presentation. In this particular presentation, I have tried to give many clinical aspects, the pathology, pathogenesis, and also quite a few X-ray and radiological features, and also the different therapy procedure for DVT and pulmonary embolism both, and also two new cases like May-Turner syndrome. And these are very high topic. If you like this particular video, follow us in Facebook, Twitter, and YouTube. In a regular interval, we are going to publish few of the videos that we have already uploaded in the YouTube. And if you like us, follow us and subscribe our YouTube channel. And thank you for listening to this. Thank you.